At its very core, drug science must remain independent. This means we don't accept sponsorships. It's with the support of the drug science community we're able to do this and make the podcast in the first place. If you're able to become a drug science community member and support the show, you too will be supporting the dissemination of evidence-based drug policies. Without you, none of this would be possible. For anybody interested, there's a link in the show notes. Thank you. Hello and welcome to the Drug Science Podcast with me, David Nutt. Here we're bringing together experts and activists for a rational, honest and informed conversation about drugs. Well, welcome everyone to another Drug Science Podcast with me, David Nutt. Today we have two stalwarts of the charity, Drug Science. Professor Alex Stevens, who's Professor of Criminology. He's managed to escape from Canterbury and he's now gone to the frozen north of Sheffield, where he's Professor of Criminology. And also with us, we have Jill Porter, who's a reader in criminal psychology. I hesitate to say she hasn't managed to escape from Belfast yet, but I'm sure if she was wanted to, she would have done. So welcome to you both. And the topic today is about harm reduction, because these two people have been leading the most recent initiative of drug science in terms of rational drug policies, and that's the harm reduction working group, which Alex set up, about 5 years ago, pre-COVID, wasn't it, Alex?
Not quite that long ago. I think it's 3 now.
Yeah, but I remember the discussions took several years. In fact, I think you even wrote a paper persuading us to set it up, because you argued quite cogently in that paper that not only do we need it, but also that there was a lot of science that would come out of it. So yeah, it was definitely something that you encouraged us to do, and we're grateful you did. But so do you want to tell us?
I'm very glad you did it, because you're absolutely right. There's huge amounts of research to be done. There's also already lots of knowledge we know about harm reduction, and there's more to be done in terms of developing and researching harm reduction strategies and approaches, both internationally and especially in the UK, which is, having been a pioneer in harm reduction in the 1980s and 90s, has fallen behind.
Yeah, we'll come back to that in a minute about the British method, etc. But I just want to point out that today was a kind of, for those who believe in psychedelics, they believe in synchronicity, a lot of them, and it's a synchronous day, because this morning, Inside Health on the BBC actually went to Glasgow and did an interview with essentially the Britain's first drug administration centre or overdose prevention centre or whatever. We'll talk about the best terminology in a minute. So it's rather propitious that you're here talking to me about that. You must, I guess, both of you be celebrating the fact that it's actually started on these islands. I wouldn't say these shores. What do you think, Jill?
Yes, I'm absolutely delighted to see what's happening up in Glasgow, and we're fully behind and in support of those who are operating that service. It seems that they've been doing a lot of great work in consulting with communities, consulting with people who might use the service. And it's a really exciting time for us here in the UK and Ireland to see this happening. And of course, it's coming off the back of an unsanctioned service in Glasgow many years ago now. We talked about before, David, as you know, with Matt Southwell, that was run by Peter Crikant, who I know was also on your podcast as well.
That's right, here. Yeah. And they're all available on the website. Thank you for flagging that. So tell us about the group. Let's tell us about what you've been up to and in terms of the drug science working group.
Okay, the Drug Science Enhanced Harm Reduction Working Group is a group of academics, practitioners, organisations who provide drug treatment and harm reduction services. And we set up under the aegis of drug science because we saw there was a gap. As I said, the UK was a pioneer in harm reduction in the 1980s and 90s in response to the HIV epidemic of that time, but that has rather stagnated. Other countries have gone forward with services that go beyond the basic range of harm reduction services. So you could say that traditional harm reduction services include things like prescribing opiates as a substitute for heroin, or even heroin itself, to people who've become dependent on it, and providing clean injecting equipment so that people don't transmit infections like HIV between them. Those are really well established and have been had the World Health Organization's stamp of approval put on them for many years now. But there are developments in harm reduction And overdose prevention centres, drug consumption rooms, safe injecting facilities, whatever you want to call them, is one in development that's happened in many countries around the world. At least 16 other countries have such services, but the UK until recently has not had a sanctioned service in their area. We're also interested in other things that are going on around drug checking. I'm sure you've had a podcast with Fiona Measham about drug checking at festivals and other places. And we're interested in developing safer drug use through people knowing what's in the drugs they might be taking. And another area we're interested in the Enhanced Harm Reduction Working Group is around what we call high tolerance housing, so that people who are unstably housed or staying in hostels don't get thrown out of their housing if they happen to be using drugs, and are helped to use drugs in a safer way even within those housing services.
So it's quite an ambitious set of goals and names. Yes, Jill.
And I think what enhanced harm reduction really is about bringing all these different services together and trying to support providers, researchers, and people who are trying to enhance the lives of people who are maybe experiencing problems with alcohol or drugs across the UK. I think enhanced harm reduction is that partnership. It really is about relationship building, and it really is about sort of helping to make a difference by sort of working out what's needed and trying to make that available for those who need it.
So let's go back a bit and work out why we fell off the pace, because that might give us a little bit of insights into how we can actually catch up. So, Alex, do you want to comment on that? Why, having been leaders, maybe re-emphasize to people, because I'm not sure everyone knows quite how we were one of the exemplars of harm reduction, particularly in relation to needle exchange and reducing the risks and the transmission of HIV. Do you want to share how that happened and then why it all fell apart, or we didn't progress?
Yeah, it used to be known internationally as the Merseyside model of harm reduction. That was a little bit misleading because it was happening in Rotterdam before it was happening in Liverpool. And the people who set it up in Liverpool also learnt from the sort of ACT UP movement in the States of people who were being discriminated against and were at risk of catching HIV because of their sexual practices. Basically setting things up for themselves in their own right, saying, if nobody's going to save our lives, we're going to do it for ourselves, and we're going to demand the rights to these sorts of services we need in order to protect ourselves. In the case of HIV amongst people who injected drugs in Merseyside, that was around things like prescribing heroin itself to people who were dependent on street heroin. It was around providing, as we've talked about, clean injecting equipment. And people like Russell Newcombe, sadly recently deceased, people like Pat O'Hare, for example, set up the International Harm Reduction Association. And that spread the word about these practices and their success in reducing HIV infection. And that became not just the Merseyside model, but the British model. It was interesting that under Thatcher's government, she was persuaded of the scientific basis that these services reduce infections. Now, on the moral side of it, it was rather disappointing that she did that on the basis that it protected people from the dangers of other people. So the wholesome community being protected from those nasty drug users. But at least it led to the investment and spread of effective services to reduce HIV infection.
And it worked, and we were leaders. And then who do you blame for the fact that we've no longer been leaders?
In a way, it became a victim of its own success. The fact that harm reduction services worked to reduce the spread of HIV amongst people who inject drugs meant that that problem became less of a political hot potato. And so people moved on, and the narrative in drug policy became that it wasn't that HIV was the problem, it was drug-related crime that was the problem. And Tony Blair was very prominent in putting forward the argument that large proportions of crime were committed by people who use drugs. So the solution became to put people in treatment to reduce their criminality rather than to improve their health. And so we had this sort of rather strange flipping away from thinking about drug treatment being about the health of the people who are being treated, and it being about saving the rest of us from people who use drugs.
Similar principle. Yeah, it was all about protecting, whether it was protecting the population from AIDS or protecting them from burglary. I guess it was the emphasis was largely on the non-drug users rather than.
the stigmatised and excluded community that were being targeted either by public health or crime measures. It's an interesting example of the overlap between public health and criminal justice measures in controlling the lives of people who are seen as threatening.
Quite. And then, of course, I guess Cameron came along, and even the health side of things didn't really figure anymore. And the shift of funding, or taking addiction funding out of health and putting it into social services, I think, has probably been a major factor in why we've had this rising tide of deaths from opiates. Would you both agree with that? Or?
Well, it's there in black and white in Carol Black's report, which she wrote in 2021 and informed the 10-year drug strategy we're currently under. She described the treatment services that she observed as not fit for purpose. And there were massive cuts under austerity, not just in the treatment services that people were reliant on, but in all the other services provided by local authorities that they relied on. So housing services were cut, the types of social support that people would need to be able to get over problematic drug use were also cut. And so you had a population that was already vulnerable, was just about clinging on to survival, and then had those supports taken away from them. And many of them unfortunately died, which is why we have the highest rates of drug-related deaths in this country that we've ever had.
And it's not just that we do, it's just we've been breaking those records on a almost annual basis, haven't we? It must, I guess that's one of the reasons you set up your working group, because it was clear that no one else was doing that. Jill?
Yeah, it goes back to some work we did for the Advisory Council on the Misuse of Drugs before I resigned from the ACMD. We wrote a report in 2016 on how to reduce opioid-related deaths, and it included several measures such as investing in opioid substitution treatment and doing assertive outreach and reducing poverty. One of the key recommendations was that the government should consider opening overdose prevention centres. Ironically, that was the only recommendation that the government actually followed, despite it saying it accepted all the recommendations except the one on drug consumption rooms. The only one it did do was consider drug consumption rooms. It considered it and then rejected it, but it said it would do all the other things and then it didn't do them. So it didn't invest in opioid substitution treatment. They didn't invest in assertive outreach. They didn't reduce poverty. And so we still see a massive need to do those kinds of things which would reduce the deaths.
And I think just coming in off the back of what Alex has been saying there, I think there's an increasing reality now that it's not just an individual level issue that affects the person who's using substances, but that this is really a structural issue, structural stigma, limited access to housing, poverty, lots of different ways of marginalisation. And we need to really be thinking about how we can get back to addressing some of those challenges. And I think that will be a key issue for the government going forward, about how they engage with these things and we try and promote health. And this is also in the context of record homelessness. We've got changes in the drug supply. So we're seeing a lot of unusual substances that haven't been here for very long, like nitazines. And so I think in the harm reduction community, we're very concerned about what the future might hold for people who use drugs, and also for the wider community of which they are a member. So I think it's timely now that we start to address some of those challenges and we start getting more engaged with things like assertive outreach. We start seeing the opening of drug consumption rooms in areas where they're needed. And we really start tackling these major challenges, because the drug-related death rates are really frightening and just causing considerable trauma to wider communities, to families, to people who use drugs, to people who work in services. It's just an enormous issue and really does need to be tackled with some urgency.
And as you know, we'll talk a bit more about that in a minute. There are both proven and also rational approaches to that. I'd like to just close off the question of why things got so bad. And I just remember it's a long time ago when I was last on the ACMD, but it was very difficult, even under the Blair government and the Brown government, to talk about harm reduction. I mean, that wasn't something. I remember there was a draft government report on drugs. We didn't mention it at all. And we had to point out that they might want to mention that, because that's kind of what the most logical way of trying to reduce the kind of problems they were trying to deal with. And I guess we now have. I mean, is that accepted now? Do you think is this part of the government's roadmap to success, harm reduction, or fighting that battle?
Grudgingly, partially, in a very limited way. So if you read the current drug strategy, you do see the words harm reduction, but pretty much only in the sections of that strategy that were written by the Scottish and the Welsh governments. The government in Westminster still has a very limited view of what harm reduction might mean. And this is why we set up the Enhanced Harm Reduction Working Group. It's not enough just to maintain the levels of opiate substitution treatment and needle exchange that have been there for decades. It's about, in the light of these new challenges, this massive rise in drug-related deaths, these new substances that are very potent synthetic opioids that are going to kill lots of people if they enter the market in a big way. We need new approaches, and we don't see much commitment from central government and some of these sort of big players in the field to actually doing more and better harm reduction, which is so necessary.
So I guess if you were to prioritise, would you put safe consumption rooms at the top of the need to try to help reduce the slew of deaths? Would you put?
To be honest, I wouldn't. I think there are things that we need to do that would have bigger impacts than that. I mean, in the long term, we're talking about reducing child poverty, because that's how you get on top of this problem in the long term, and that's a massive issue. But in the short term, the most effective way we have of reducing drug-related deaths is by getting people into opioid substitution treatment. And the government, to give its due, is trying that. They've got a target to increase that. They're struggling to do so, I think, partly because they're limiting their vision of what attractive treatment services are. For example, we know that heroin-assisted treatment, the prescription of heroin itself to people who are dependent on heroin, is very effective at engaging and retaining people for whom other forms of opioid substitution treatment like methadone and buprenorphine don't work. But the government has repeatedly refused recommendations from the ACMD and others, including several parliamentary committees, to expand heroin-assisted treatment. So I think we've got to get opioid substitution treatment right. We've got to make it much more attractive to the people who it's targeted at. That would include heroin-assisted treatment. But alongside that, in the places that need it most, and we know where those places are, we can see it in the death rates. Glasgow, Dundee, Blackpool, parts of the northwest of England, South Wales, some of the coastal towns in the south of England, we see very high rates of drug-related deaths. And some of those places have quite a lot of public injecting. And those are the sorts of things that overdose prevention services can reduce.
Well, do you want to explain to people? Yeah, because the terminology is, it's changing. It's overdose prevention, safe injecting. Tell us, the audience about what the vision is there, please.
So it sort of depends. I think we've often gone for things like Overdose Prevention Centre because it emphasises the urgency of the drug death crisis. But I think we're moving more towards the enhanced harm reduction services because basically thinking just on the back of what Alex has been saying there, it's really about integrating services together. And when Alex was talking as well about how sometimes services are not necessarily appealing to people who use substances who might benefit from them, part of that is also just the fact that many of those individuals may have had doors slammed in the first place. So they've reached out to services and it hasn't gone particularly well, or they felt really stigmatized, or it hasn't met their needs in some way. And in some ways, the enhanced harm reduction service, drug consumption room, overdose prevention centre, or whatever we're calling it, by being a kind of a one-stop shop that kind of brings together lots of different harm reduction under one umbrella, can really help sort of bridge that gap in many ways by kind of creating relationships that are trusting, that are based on non-judgment, on things like, not forcing people into treatment. And actually, you do see that some people even go on to things like abstinence-based treatment, as well as things like heroin-assisted treatment and methadone maintenance as well. So there's a lot of different things that the services can do, as well as preventing overdose deaths. But to make a difference, they have to be in areas where they need to be situated. And also in Belfast, we would have some of the highest rates of young people dying. So the kind of Good Friday generation, so people who kind of became adults after the Good Friday Agreement was signed 25 years ago. We've got really high death rates there, and we're just not able to provide the services there to meet their needs. Enhanced harm reduction services can fill that gap and provide those kind of services, and provide drug checking, and provide equipment and swift access to other healthcare as well.
We'll come back to drug checking. I didn't know you could provide drug checking, but I see that Alex has his hand up.
Yeah, it's just really interesting what Gillian has just said about these enhanced harm reduction services, because people tend to focus almost obsessively on the fact that in an overdose prevention centre or enhanced harm reduction service, you would have people injecting or using drugs. And people can't get over the idea that, oh, that's terrible. People, you're facilitating, you're enabling, you're doing all these sorts of things that we don't want to be happening in our communities. But the two problems with that is that, A, these things are happening anyway. And surely people would rather they happened indoors in a safe and hygienic place, away from the public gaze. I mean, both people who are using drugs on the street and people who are just walking by on the street don't want to see people using drugs on the street. They don't want to be using drugs on the street. They'd much rather be doing it in a safe, clean, welcoming and warm place. But going with that is it's not really about the drug use. It's about the lives that people are living. It's about providing a space where they can feel a thing that is quite rare for a lot of people who are using drugs on the street. They can feel safe. And safety is the basis from which you can then start building trusting relationships. So we keep on saying, why, oh, why are people not engaging with services? Why, oh, why are people continuing to live lives that we don't want to be living, them to be living, and they don't want to be living? And it's a lot of cases because they're so trapped in dangerous, stigmatizing, rejecting situations. And an overdose prevention centre and enhanced harm reduction service can be a first step towards creating those sorts of connections that one needs to be able to trust, to have connections to other services that can help you move towards a life that you want to be leading, safely housed, employed, in relationships like we all want to be. And so it's not, people get so confused with the idea that that an overdose prevention centre is somehow an outlandish place where people are going to be doing nothing else but injecting drugs. That's the least of it. It's about creating safety, trust, and social inclusion.
Yeah, but that's an active choice of belief, isn't it? And we haven't mentioned this is the horribly stigmatizing term shooting galleries, but I think maybe we've won that argument. Maybe even hostile politicians don't use that anymore. In the media, we've managed to curb it. But this way of many people seem to think and choose to, well, not think, but choose to act in relation to this is very hostile to the. And it's I suppose a relic of the. We've got to punish people who use drugs, and the idea that they're actually having safe using is actually going to encourage. I mean, there's so many myths about that, and I don't know how we meant. We've not completely shifted that because let's face it, we still haven't got we haven't got a safe injecting room in England yet, have we, or Wales? I mean, and that's still because there's a lot of resistance. So where is that resistance coming on? Is it prejudice, or is it maybe I should ask Jill as a psychologist? Do people actually choose to hate people who use drugs? Is it sort of some kind of sadistic belief that some sort of sadism, some hatred? I mean, why do people hate drug users? I've never kind of understood that, because most of them are really struggling with enormous problems, and most of them have been victimized before they've even taken drugs. But do either of you have any views as to why we take such nasty attitudes to them?
Well, I do think stigma prevents service provision, really. And without wanting to say why people hate drugs or try and put words in other people's mouths, we do know that there can be, when we treat people who use drugs as othering and undeserving, we ignore their needs. And this allows us to keep going with things like structural stigma and limited access to interventions and things that could save people's lives, improve their lives. But I think it's really about sort of reducing labels. And you were talking there about shooting galleries, and I absolutely hate that term because it's just designed to get us all excited and riled up for no real reason at all. But if we can consult with communities, including those who use drugs and those who don't, it's really crucial to effective care and effective solutions for communities. And we've mentioned before about structural stigma, poverty, housing, other kinds of marginalisation, education, legal discrimination, all of these different things just limit what we can do to support people. And there's almost a sense that they're undeserving in some way. However, it's essential for public health. It's essential for communities. And people who use drugs are members of our communities. They're out in our communities, very visible and quite quite often, and they're as deserving of help as anyone else. And I really do think it's essential we kind of change our attitudes. And part of that is just having conversations. Lots of people have different views, and it's really important that people feel heard, particularly if they're thinking about an enhanced harm reduction service in their local area. People will have genuine concerns, and they're allowed to have those. It's really important that we listen to people. And I said this, I think, in the last podcast, but it's important to hear from people who have those concerns, because many of them have been worked out over the 17 different countries that have ran an OPC, the 200 facilities around the world. There are solutions there to make it a solution for the community, for people who use drugs, for families, for healthcare, for police even. There is an opportunity there to really make a big difference, but only in an area where it's particularly needed. You don't want them everywhere. They don't need to be everywhere. They're not going to be cost effective everywhere. But where there is a need for an enhanced harm reduction facility or drug consumption room, they can make real differences to communities.
Look, raising the topic of the police, that interests me. There's presumably there's some disagreement within the police as to whether these are good or bad. I mean, how's that changing?
It's interesting that the police people that I discuss this idea with, which, is a range of officers from street level to, extremely senior police officers. And these days I don't tend to get much pushback on the idea of it. It's not that police officers aren't aware of the problem, and it's not that they don't have compassion towards some of these people. I think there's a lot of stigmatization of the police as well. The policing is part of the problem that these people face, and so a lot of the reason that people would want to use an overdose prevention centre is to get out of the gaze of the police. They don't want to be constantly harassed and moved on and arrested, and that is, we know from other research, not good for those people, and it's not good for the communities either. Because, for example, we know that when you do a major drug bust and you take lots of drugs off the street, that you tend to increase violence because you create a vacuum which has to be filled by dealers, and they tend to fight for that. So we're doing a lot of counterproductive policing. Police officers don't tend to speak about the counterproductiveness of the overall drug war. They tend to talk about the counterproductiveness of repeatedly arresting the same people again and again. They come into the police custody suite. They're there, and then they get arrested. They get a caution or a fine or sent to court, and then 2 days later they're back again. They know how pointless that cycle of criminalization is, and so they're interested in doing things differently. I think one of the things that holds them back is the Home Office and successive Home Secretaries insisting something that's not true, which is that it's illegal to run a drug consumption room, an overdose prevention centre in the UK. UK drug law does not make it an offence to run a space where people inject heroin. So it's not true that it's illegal to run an overdose prevention centre if it's just a place where people inject heroin. If they don't inject each other, there's no dealing going on. It is, however, still a criminal offence to be in possession of these substances. But that's the case for a lot of services that we already know about. For example, needle exchange programs, which we were just talking about how they've been going for decades. Obviously, people using needle exchange services are also in possession of Class A drugs. Indeed, when they hand their needles back, they have got Class A drugs in them. And so people have argued, ministers at the Home Office have argued, well, it would be illegal to run these services because people are obviously in possession of drugs. Well, yes, but that's the same for lots of other health services that we tolerate and indeed fund for people who use drugs. So this argument that's made from the Home Office downwards has put the frighteners on many people in local authority services and the police, who don't therefore want to put their name to a service which they've been told by the Home Office is illegal, even though it's not.
Yes, and I guess that's what happened in Scotland. I mean, Peter took it on and he's still free. Jill?
I think it is, we see that police as well have to shuffle people around cities. So they're quite often the first person that is called whenever maybe somebody is publicly using substances on the street. So the police turn up and they've nowhere to send anyone to. Also, they have to deal with drug-related deaths that are sort of unexpected. There's also a burden in relation to that as well in terms of both trauma. I'm a psychologist, as you know, so we always go there. But also just dealing with that and the families and all the bereavement and all the different things that are going on there. But they don't really have very many other options until the legislative position changes to make it a lot more supportive. And we do see this in locations where there are enhanced harm reduction services, drug consumption rooms, etc. We see the partnership is so strong between the police and the service, and really successful services are ones where there's like a really good sort of network where, you know, the service will call the police and say there's something going on, can you sort it out, or vice versa, and it all goes away before anyone really even sees that it's happening. And so they're really crucial partners, not just in a sense of helping the running of an open service, but also they're some of the biggest referrers into a service. We've seen this from European research, that they're a big part of sort of trying to support communities in relation to substance use.
So how do you pull it together then? I know you guys have been thinking for quite a few years as to how we can set one up in England and Wales. I mean, what does it take to set up the enhanced service? Which bodies need to come together, and what do you need?
Yeah, well, 3 years ago, I wrote this down as a process 3 years ago, and it was partly around community mobilisation, around working with drug treatment providers and harm reduction providers, working really importantly with people who use drugs and people involved in street-based injecting to find out what their needs are and what they want to come out of such a service, and also putting the work in to do the research to say, well, what's the evidence here about not only whether these things work, but how they work, so we can design them in a way that meets the needs of the people who are going to use them. So Gillian and I have just recently finished a project which was funded in order to do that research, to prepare for an evaluation of a fully operating overdose prevention centre in England or Wales. And so we did a review of the evidence. Gillian's prepared a tool for measuring the outcomes of these services, created a service model by which people could run an affordable overdose prevention centre, and our colleagues Peter Vickerman and Adelina Artini at the University of Bristol have done an epidemiological model that shows, you know, what the effects might be and how cost effective it might be to set these up in terms of reducing the burden of the NHS of the infections that people catch. So I'm sure that Gillian would love to tell you about the model.
Go on then, tell us about the model, Gillian, and tell us who's going to pay for it as well.
Well, it all depends. And of course, we have the Scottish model that's about to open, which is quite different to how I think other models across the UK might operate. It's much more sort of medical led, and that's sort of part of the legal framework that allows it to operate up there. And it's been done very nicely in collaboration with people who use substances, which is really setting it up for potential success in delivering healthcare to people who need it in Glasgow. I think probably elsewhere in England, Scotland and Wales, or not other places in Scotland, Wales and Northern Ireland, I think we're probably looking at different models, everything from mobile sites to integrated healthcare sites, but possibly slightly more separated from, say, hospitals and so on, because they tend to be slightly cheaper if they're run by nurses or drug workers. And that's probably more likely to be the model that we're going to see elsewhere around the UK, just for the very nature of the amount of money that's in and around for things like services in this way. So I think it really sort of depends. And again, it's also about, you know, what's happening in an area. In Belfast, we see a lot of injecting cocaine use currently. In other places, there are other substances of interest. And it's really about tailoring it to the people that it's supposed to be serving, linking in with the wider services that are available. We want to be linking in, even if they're not on site, to treatment services of all different kinds, physical health treatment services, thinking about sort of injuries, thinking about HIV, thinking about hepatitis. And we want to be thinking about other kind of supports that people might need. We want to be thinking about opioid substitution treatment. And just we want to be sort of seeing these things as sort of integrating into wider communities. It doesn't always have to be on the same site. It can be a mobile site, as Peter Crichton's van was, that sort of travels around to provide this information and support. And crucially also, sorry, I forgot, sort of needle and equipment exchange is really important as well. So it's really about tailoring to the area. What's going on there? What are the concerns of communities? What are the concerns of people who use substances, and making sure that it really tailors to that. But it's probably quite unlikely we're going to see much of a replication of the Glasgow model elsewhere.
Yeah, there are some interesting common features of overdose prevention centres that have been set up in these 17 other countries. And the ones that are not mobile, the ones that are in a static building, they tend to have a reception space where people come and are welcomed and can talk to people while they're waiting to use the next room, which is a place which has cubicles which are hygienic, where they can use clean injecting equipment and be observed by a nurse or other person who can intervene with first aid, oxygen, naloxone if necessary, if they overdose. And then a third space where they can chill out and relax and make sure that they're safe before they leave. So that's the sort of the bare bones of what an overdose prevention service looks at. But as Gillian said, there's a whole lot of stuff that goes around that is dependent on local need, dependent on what the local network of services are. And we're not talking about spaces that just provide a space for people to use drugs. We're talking about people to a network of support.
Yeah, well, I vividly remember visiting the Vancouver Centre, which was actually a converted cinema, and it had, I think, 7 or 8 bays within view of a couple of nurses and healthcare workers, and it was impressive in its scale. But I think Vancouver did have a sort of Scottish level, Glasgow level problem, and probably still does. But the challenge has always been to try to get funding from the different groups that are going to be benefiting. And so it's coming over as something that's really quite, I suppose, going to be quite dependent on public health. I don't think police are going to fund it, are they? Well,
one of the reasons why we worked with our colleagues at the University of Bristol to do this epidemiological model, which included an estimate of what it costs. And because of what we know from other overdose prevention centres around the world, we know that they reduce hepatitis C infections and that they reduce the incidence of cutaneous infections, wounds. And these things are really expensive to treat, and they take a long time to treat. And so even though there's obviously a cost to setting up overdose prevention centres and harm reduction services, the model suggests that within 5 years, you're gaining that money back in terms of the reduced costs of not having to deal with those infections. That's even before you take into account the reduced costs of things like ambulance call-outs. So another aspect of the evidence we reviewed is that when you open an overdose prevention centre, you tend to get a reduction in call-outs to ambulance services. You get a reduction in the use of people going to A&E departments, and those things are really expensive. So even without taking those things into account, we see that there's a cost saving attached, and this would be. It's one of the good things about these are costs that are in the same budget. Often when you're investing in drug treatment, you're doing it. You're investing the health budget to save money in the criminal justice system, and that's quite an hard argument to make here. We're investing health money to save health, and so in terms of the new government's mission to fix the broken NHS by moving everything to prevention, the overdose prevention service and enhanced harm reduction services are fully on message at that part of the mission, even if politicians don't like to talk about people using drugs.
Well, that gets me on to quite an important question now. So we do have a new government, and they're certainly talking a new mission. How do you feel? I mean, are there feelers already? Do you think do you have a sense that wind may be blowing more in your favour?
I don't know about Gillian. It didn't blow that much in our favour in terms of harm reduction during the last Labour government. It was only this argument that investing in drug treatment saves money in the criminal justice system that levered money out of the last Labour government. That was very effective, and it ended up reducing deaths as well.
Yes, exactly. Yeah.
So I don't see yet a lot of movement in drug policy from this Labour government. There's some interesting possibilities. So, for example, the woman who's been made Minister for Policing and therefore is in charge of drug policy was Dame Diana Johnson. And before the election, she chaired a very
She did.
interesting...
I gave evidence to it. Yes, absolutely. I thought she was very impressive, yeah.
Yeah, and the report of that committee, for example, recommends that we should be piloting overdose prevention centres. Whether that commitment will survive into government is a different matter. After all, let's remember that David Cameron also chaired a committee of the Home Affairs Select Committee, which recommended a much more radical approach to drug policy before he became Prime Minister, and then that was rather forgotten when he was Prime Minister. I learnt from my late friend Thomas Zabransky the phrase post-retirement enlightenment syndrome, the idea that people tend to see the light after they've retired when they no longer have any power to change it.
I think we've seen that with a lot of drugs ministers, haven't we? Well, they don't have to retire; they just have to step down from their job.
Yeah, but there's also a pre-possession disenlightenment syndrome where people lose their radicalism as they enter government. So we'll see what happens with the Labour Party. The Labour government obviously wants to put our feelers out and reassure that these things may not be as unpopular as they think they are, especially if they can be shown to bring people into communities in a way that reduces some of the harms that are being done both to people who use drugs and the communities around them.
And just to come in off the back of that as well, I think it's not just about drug policy too, which is certainly an expert area of Alex's, but I think it's about some of the other sort of structural factors around poverty, limited access to housing, education, marginalisation, legal discrimination are really, really important as well. Things like homelessness, violence against women and girls. These are, I think, priorities for the government coming in. And of course, there's an enormous overlap there in relation to what's happening with people who use substances. But I think, both Alex and I, as part of the Enhanced Harm Reduction Working Group, are really interested in speaking to any politicians who are unsure or unclear about some of the benefits of engaging with some of these initiatives, particularly if they're skeptical, I think, because there's a lot of evidence out there and sometimes it's not that easy to sort of work out what's going on. But we are keen to have those kind of conversations and, quietly, if need be, about some of the challenges that they face in making calls for the population, including all the different regions of the UK, which all have enormous challenges to face in relation to substances and the harms that are sadly not being prevented.
And what about the media? How are we going to? I mean, because obviously you're working with the most stigmatized group of people in the most deprived parts of the country. How do you get Middle England to take this on board? I mean, given that they've got a strong moral opposition to people who use drugs, I've always thought that the only way to really have a debate would be about the economics and the value of it to everyone. I mean, which is part of what you're saying. But I mean, do you think we can get, because I'm sure it's largely most of the media that have been hostile to this. I mean, you don't see a lot of support in the media for it. Or do you sense it changing? Do you think you're beginning to win the argument?
It's a rather depressing thought, isn't it, that people will only get behind drug policy reform if they think it's going to save them money. These people, we can have an argument on the basis of the value of human life and human dignity. And it's interesting that was an argument that has been had in Scotland and is behind some of the changes, I think, that are happening in Scotland. So, in about 2019, I think it was when the number of drug-related deaths in Scotland crossed the threshold of 1,000 per year, it became a big scandal in Scotland that so many people were dying, and it became almost a national embarrassment that so many people were dying. And the Daily Record, which hadn't been known to be particularly liberal before then, started campaigning for decriminalisation. Both Baroness Ruth Davidson and people who would be much more left-wing than her started saying, how terrible it was that so many people were dying. Even the then head of the Conservative Party was persuaded not to oppose the opening of overdose prevention centres on the basis of the value of human life. So I'd much rather we were having the argument on the basis of human dignity and the sanctity of human life than the economics, even though the economics quite often are more persuasive. I think the way we might be able to shift that argument to thinking about the value of life is by just allowing the voices of people who use drugs and their families to come through. Maybe get people like you and me, David, off the airwaves and get onto the airwaves, the families of people who've died with drugs, the people who are struggling with drug use at the moment, and just listen to what their stories are. Listen to why it is that they're in these desperate situations. Listen how important it is to them that they have a space where they can feel dignity and safety. And I think once we start creating those human connections, what I call affective stories, the things that trigger emotion and sentiment and mood, that's sometimes more important than the economic calculations and the policy proposals of overeducated men like you and me, David.
Well, I would certainly endorse that. And if you want to do it through these podcasts, then obviously, come back to us, because it's, although I'm not sure our reach is quite as much as some of the less enthusiastic papers, but I take your point, Jill.
And I think it's worth acknowledging how important public opinion is, because it plays a big role in whether a centre or an initiative is feasible, it lasts. And we're seeing in places like Canada whether it expands to areas it's needed. And I think, as Alex was saying there, that kind of exposure and understanding from knowing someone who uses drugs or hearing their story is really essential to that. The other part is, and I know I keep going on about the sort of structural determinants of health, but I think as well, sometimes in the media, we see a big focus on individuals using overdose prevention centres, enhanced harm reduction. It kind of ignores some of the other issues that are going on there, that poverty, trauma, etc., reduces people's sympathy and just helps to keep that sort of marginalisation and sort of stigmatisation going, with this idea of whether people are worthy or not. And that has to change. I think there are some really great journalists out there who are doing the best they can to try and sort of change that rhetoric. I think there's still some distance to travel. But for journalists, it is a real responsibility, I think, to be talking to wider communities, to the population. And I urge them to try and sort of think about that very carefully in their reporting. And it's great to be on the podcast and talk about this topic. We're very interested in letting people know through the podcast more information.
And thank you. And there's one other thing that I think many of our listeners won't fully have understood, was the comment about high tolerance housing, because this is, to me, a relatively new concept. Is it one you guys invented, or whatever it is? Tell people about it, because it's a really interesting construct.
It's certainly not something that I invented. It's something that people came to us with. So, it's, for example, there are people providing housing services to people using drugs. And one of the most terrible things they have to deal with is people dying in the services they provide because they overdose. And some places that provide housing have policies which say you can't use drugs in here. If we find you using drugs, we'll throw you out. And that's partly to cover their own backs legally. And you can see why they do that. Their insurers might insist on it, those sorts of things. But what it means is people won't let people know that they're using drugs in the property. And so if you hide the fact that you're using heroin and you get a bad batch, or your health that day doesn't tolerate that heroin, and you haven't told anyone that you're doing it, then you're very likely to die. Heroin, as you know, kills people by suppressing the instinct to breathe. The people aren't shouting out and saying, "Help, I'm dying." Their breathing slowly slows, then stops, and they die very quietly. And nobody's going to know that. So the concept of high tolerance housing is that you say, well, we've got a population here using our housing services, and we know they're going to be using drugs either on the street or in this housing. And we would prefer they did it in the safer place, which is in this housing, and they can tell us they're using these substances, and we can keep an eye on them so that they don't die. It's as simple as that. And one of the services we've spoken to that has adopted that model went from having tens of people die every year to tiny numbers of people dying, because people were saying, I'm using, and they could look after those people. That's what they want to do.
I suppose they could have naloxone available in the house as opposed for the individual persons as well, couldn't they?
That's right. It's, naloxone should be available. It's government policy that naloxone should be available to everyone who's at risk of overdosing on opiates. This is just a way of making that happen, connecting the person with the medical care they need. Indeed, in many cases, many people who run overdose prevention centres have realised they don't need to go to the naloxone because they can spot the signs of somebody who's vulnerable to overdosing. They can see their breathing reducing, sometimes through just simple first aid measures, sometimes through the provision of oxygen. You don't have to go to what is quite a radical step for somebody who's got lots of opiates on board to give them naloxone to sort of block all that opiates in the system. So you don't necessarily need to get to the sort of...
Certainly prefer not to.
Exactly. You can prevent it happening even before you get there. So we just see that as another rational extension of the idea of harm reduction, that if you know you've got a service that is possible to prevent people dying, well, why wouldn't you do that?
Are there guidelines? I mean, because obviously to become or to run or whatever, I don't know, to allow your facility, your block of flats to become a high tolerance. I mean, presumably it takes a bit of courage and a bit of skill. I mean, are there good templates as to how to do that? Do you have guidance, etc.?
There's not enormous amount of guidance at present. I think a lot of services are sort of developing their policies and sharing them amongst fellow services. There's not been an awful lot of research there. There's a little bit in other places, Canada being a notable example amongst others. But I think it's really important that that sort of thing is slightly more formalised. Maybe even things like we recognise these kind of services in something as radical as the NICE guidelines, which sort of govern other aspects of healthcare, because essentially that's what it is. And high tolerance housing also facilitates a reduction in homelessness, which is an enormous issue and an enormous priority for the incoming government, and sort of trying to sort of reduce the sort of harm that's happening to people who are vulnerable on the streets, including women, including young people. There's a lot of risks that can be avoided if we just accept where people are at and try to work with them at that position. And that said, it is difficult for individuals to run services, so it's not a judgment on that particularly. But it's starting to become really important that we start to see that whole person who's in a vulnerable housing situation in a homeless hostel, and that we're supporting them through that. And we have a lot of great services across the UK and Ireland who are sort of leading the way, and us researchers are sort of catching up somewhat and trying to support them in whatever ways we can.
And every precedent, of course, makes it much more comfortable for the next person to come along. So there aren't any examples of people having been prosecuted, are there? I mean, can we say that the law's given up on trying to be vindictive for these kinds of arrangements?
You might remember, David, a few years ago, and it's quite a few years ago now, the Winter Comfort case. And there were two people who were running a homeless hostel who were prosecuted because it was found that they were allowing dealing to occur in the property they were running. Now that's obviously a legal precedent we don't want to see happening. We don't want the staff who are running these services to be exposing themselves to that sort of legal risk. And one way of doing that is by having clear guidance that says, that there's going to be no dealing, and these are the steps we take if we suspect dealing. So, if services are thinking of developing these types of services, they need to be clear about how they're going to manage that legal risk to themselves. These things could be changed by, ministers changing the law to make it easier to run services that save people's lives. I mean, to go back to the Overdose Prevention Centre, for example, we've recommended to the government, and the Faculty of Public Health have joined us in that call, that we should change the misuse of drugs regulations in order to make it easier for medical staff to be involved in running services where people will inject drugs. It's, as I said, it's not illegal to run such a service, but a simple clarification of the misuse of drugs regulations would reassure and make it easier for drug treatment organisations, harm reduction services, to run these types of services, and that would include high tolerance housing as well.
Well, I think I can truthfully say if any individuals are going to make the case that will affect change, it's going to be you two and your team. Fantastic to talk to you both, and I hadn't realised quite how effective this most recent of the drug science working groups has been. Congratulations on what you've done, and keep up the good work. And we'll celebrate, hopefully, in a couple of years, a major shift in attitude and policy. Thank you very much, Alex and Jill.
We'll celebrate in my favourite drug consumption room, which is a pub.
Yes, indeed. Yes, but we might have to drink non-alcoholic functional drinks that I'm inventing as well. But I'll provide them for you. I'll provide them for free. All right. Thank you both so much. It's been lovely talking to you.
And you.
Thank you.